everyone. This is Patient Day Costs Guidance Agent. So here it helps to monitor real-time hospital operational signals and guide supervisors to early staffing and resources decisions that reduce cost per patient day without compromising care quality. So Uh, hospital leaders often review cost per patient day after the shift ends. This problem is that staff and supply decisions are already logged in by then. So this solution shifts cost discipline into real-time operational execution. So let us take the first use case for this agent, staffing flex opportunity. So let us give the prompt. Show units where patient census has dropped but staffing hasn't adjusted. So here, this agent identifies the ICU, patient census and acuity have decreased, but staffing levels remain unchanged. Instead of waiting for end of the shift review, the agent recommends flexing staffing down and rebalancing the skill mix immediately. So you can see units with census drop, but staff ratio did not adjust. So ICU cost risk status. So 8 to 9, census is 18 to 17. It is dropped down. And 12 to 15 means 12 to 3 o'clock. 20 to 17 it is dropped down still. So recommended action for this is flex down 1 RN, rebalance skill mix, tighten break and relief plus task coverage. So operational cost is controlled before the patient day is complete. So let us go for next use case, that is supply use case escalation. Let us give the prompt. Identify units where supply usage exceeds expected levels for current activity. So here the agent flags the mid-surge unit. Activity is stable but supply usage intensity is above expected thresholds. The supervisor is guided to intervene immediately before additional cost accumulates. So you can see mid-surge cost risk status. Time 8 o'clock, average acuity is 2.8 and supply usage is index. These are all the other timings and average acuity and supply usage indexes. So we can interpret this pattern suggests process-driven overuse, not patient-driven need. So common drives at this acuity level is routine kits open just in case, duplicate wound care, that is force supply, and high cost disposals used as default. Also, it tells about ICU cost risk status based upon time, average acuity, supply usage index, and also step down cost risk status and the summary of med-surg, ICU, and step down. So let us give out the prompt. Show stable operational units. So here the agent identifies units operating within expected staffing and supply thresholds and recommended continue monitoring. So you can see the step down unit caustic status is like stable operations. Patient census is 18 appropriate for unit capacity. Average acuity is 3.1 aligned for staffing model. Staff to patient ratio is 1 is to 3.1. adjusted appropriately after census drop. Supply usage index is 1.06 below risk threshold. The risk threshold is 1.1. So responsible team is unit supervised nursing operations. That's all. So you can see the summary of the step down. Step down is stable and ICU and med surge is actively risk. So this is not about reducing cost after the fact. It's about making early operational decisions while still room to act. That's how cost per patient day becomes an execution discipline instead of finance metrics. So I can say healthcare costs don't speak suddenly. They drift though through delayed operation decision. This agent helps team corrects the drift in real time. Thank you everyone.